Hi, and welcome to the 2021 Technorama. My name is Steve Bruno, and I'm a denturist. I've graduated in 2004 and have been practicing since then. Today we're here to talk about a great product from Cube Innovation called the InnoBite. The InnoBite is a bite measuring device that allows us to quantify a patient's bite force. We know when we ask a patient to bite, the nervous system is activated. We also know how complex the nervous system is. The muscular system is a very complex system. There are many muscles being activated when we are closing our mouths or clenching our teeth. The muscles of mastication, which include the masseter muscle, the temporalis, and the medial and lateral pterygoid, are all muscles that elevate or protrude our jaw or give us side-to-side movements. The masseter muscle is one of the most important muscles when establishing a bite. This muscle, when activated, will elevate the jaw, the mandible, and give us our bite force. Another muscle we should discuss is the buccinator. This muscle helps us swallow our food and also aids in chewing. So there are so many muscles that we need to remember we're dealing with when we're asking a patient to bite. So now we can bring a technical perspective to our consultations. Instead of us thinking to ourselves, I wonder if if they're eating their foods properly. Are they swallowing their food whole? Other than us previously, just by asking questions to all of our patients, such as, do you have difficulty eating? Do you have difficulty swallowing? Do you limit the foods you eat when you are at a restaurant? Now we can use or quantify by using a number to establish how exactly they're eating and what they're capable of eating. A lot of the guesswork when talking to our patients is gone because we've quantified using a number from the InnoBite. The InnoBite is the first patented device on the market. It's a great tool for dentures to use, especially since we're dealing with prosthetics and we do this every day, all day. It provides us a scientific measurement and allows us to treatment plan accordingly without having any measurement to quantify a bite force. We get into that guessing game again, as I mentioned previously, on treatment options. So before the InnoBite was around, we had basically articulating paper to establish one's bite force. What does articulating paper really tell us? Well, not much. It will tell us where the bite is heavy, where the bite is slightly touching, but it doesn't quantify how strong a person can bite. The InnoBite does just this. It gives us a measurement that we can then see and use to treatment plan the case for our patient. It helps customize all treatment options to an individual patient. Historical devices. Well, there haven't been many historical devices up until the InnoBite was produced. One being the dynamometer, or strain gauges, or T-scan. Now, I'm not sure about all you folks, but if I placed the strain gauges in a patient of mine, I don't think they'd be too happy. The T-scan is a great scan. However, what it does is it will record where a patient bites first and second and third and so on and so forth. But if a patient has a high bite force or low bite force, the results will be the same. So until now, there has been no device on the market to record a proper bite force of a patient. Why do we measure bite force? Well, as denturists, essentially we're measuring bite force every day, just not really knowing we're doing that. What a bite force measurement can do for us is determine what type of materials we want to use. Do we use lingualized occlusion? Do we use 10-degree cusp? Do we use 20-degree cusp? All these factors play a role into a patient's bite force. Without having a proper number to quantify a bite force, essentially we're guessing. It also helps us communicate to patients what exactly it is we're trying to do for them. So yes, we're trying to make them a denture, but without having a proper bite force measurement, are we actually doing that? Does the VDO need to be increased or decreased? What establishes a patient's ability to chew food is their bite force. Many materials out in the market will allow us to do that. If a patient has a high bite force, do we use porcelain teeth again versus an acrylic or composite resin? These are all factors which will essentially allow us to have a successful case or a case that really didn't go the way we wanted it to. It also allows us to determine the treatment options for implant fixed or removable restorations. Up until now, I don't know, when I send a patient to a surgeon for a consultation of a fixed restoration, they have their CT scan, the surgeon will send us a copy of a report saying, yes, the patient can have 4, 5, 6 implants. But do we really have a say in the treatment option surgically as denturists? Not really. So by having a proper bite force, we can help a surgeon understand what type of factors will be applied during normal mastication. If a patient has a very high bite force in our consultation, we can tell the surgeon that yes, I think six implants is much better than 4 because of their bite force. All these factors will help us have a successful case and a happy patient. How do we measure a bite force? Well, it takes all of about 1 minute to do. We would simply insert the mouthpiece into the patient's mouth using a one-time use cover. We line up the incisors on the indicator provided on the mouthpiece and ask the patient to clench or bite as hard as possible. Ideally, it's great if the patient is sitting and with their head straight forward and in a non-supported position. There are 4 types of bite force that we can measure: high, normal, light deficit, and low. Guys, I haven't had this product for very long, but I've noticed that majority of my patients are in the low bracket, under 200 Newton centimeters of bite force. I myself, when I tested the bite force on my initial consultation, hit 1700 Newton centimeters, and I believe Frederick, the owner, was actually shocked and never saw anything like that before. I told him it was from making all those lower dentures for our patients. So anyway, it's a pretty easy chart to follow, and it allows patients to see exactly where they are on the scale of bite force. So the first area we're going to discuss is the low value on our chart of bite force. This is the most common area that as denturists will probably encounter, as I previously mentioned with some of the patients I've tested. Some of the causes of a low value of bite force would be paro, TMJ disorder, missing teeth, or resorbed ridge. Many cases, the materials we conventionally use tend to hold up during mastication or a prolonged period of time, such as acrylic, composites, any one of the basic materials we use on a day-to-day basis would work for a patient of a low bite force. So some other causes of a low measurement on our scale would be improper or poor adaptation of our dentures, injury, instability, A lot of times, sore spots in dentures, patients feel pain or discomfort, or they compress the nerves when they're biting, will all cause a or help cause a lower bite force. Sometimes traumatized muscles or traumatic injuries from the past will also attribute to a low bite force. So, what do we do when a patient presents with a low bite force? Well, we start giving them options. The best result to achieve a higher bite force is a dental implant treatment. By achieving a stronger bite force, the patient will be able to enjoy their quality of life, definitely, absorb the food or absorb the nutrients that they're supposed to when chewing, and break down food properly so the digestive system is working properly. Quality of life and self-esteem issues with people with a low bite force are a big portion of that. A lot of times you'll see patients come in and they do this, they're covering their mouths. Again, it's due to an instability of their dentures. Or they go to restaurants and they're eating soup when they really want to eat, a steak or a piece of chicken or something that they truly enjoy. With a low bite force, it's almost impossible to chew foods that you want, foods with a higher density that are tougher to chew and actually break down and digest properly. When a patient presents with a light deficit, the nutritional deficit is not an area of much concern. However, it can still be increased with an implant-supported denture. That being said, things that we need to look out for are lateral excursions during working and balancing, or protrusion, which is another movement that can cause greater wear or breaking of your dentures during mastication. And more precise materials when designing our cases. So, with a light deficit, is there a need for a mesh in the upper, possibly the lower? These are all areas that we need to consider. So with a light deficit bite force, some choice materials we can use are PMMA and acrylics. However, if we optimize our treatment plan, we know that in a few months down the road, if we remeasure bite force, the bite force will probably increase. Therefore, we have to sort of over-engineer the case, assuming that will take place. We all know that if a patient presents with a decreased VDO and they're overclosed with their existing dentures, even with a light deficit, by us correcting the VDO with their new set of teeth and giving them proper occlusion, their muscles will be activated and strengthened. Therefore, we need to take that into consideration when designing a case. So some of the reasons to opt for dental implants with a light deficit bite force are to prevent bone resorption, to increase comfort, definitely, and also quality of life and self-esteem. I mean, many times patients come in and, unlike a low deficit, may not be covering their mouths, but do they really know what they can achieve with an implant-supported denture? How much better will their quality of life be socially, functionally, so on and so forth? These are all things that need to be discussed when determining a proper treatment plan. The aesthetics as well. We have a lot more options when implants are a part of our treatment plan, because we can place teeth exactly where we want them without having the instability of a conventional denture. So patients that present with a normal bite force have the ability to chew basically whatever food they want to eat. However, a lot of times what I've noticed is these are patients that are partially edentulous, so partial denture patients. Many times patients come in missing their posterior teeth and say they don't really have a problem chewing, so on and so forth. However, we do know that studies show our bite force is highest in the molar region, then premolar region, and obviously, last but not least, the anterior region. By fabricating a partial denture, especially on a free end patient, we can increase bite force even more, allowing the patient to properly digest and chew their food. In the normal bite force range, the 650 newton centimeters to 1,000 newton centimeters, mandatory reinforcements for our prostheses should be included in every design. By using the InnoBite and showing the patient how heavy their bite force actually is, this will help us discuss with the patient treatment options as well as the cost of additional materials being used. Whether we use fiber force or a metal mesh to reinforce a conventional denture, or for a fixed case, do we need a pectin or PEEK absorption material or cast chromium cobalt to help absorb some of the bite force and distribute it evenly to prevent further fractures and breaks is very important. As it really helps us with cost too for a patient. No one likes surprises at the end of the day once they've agreed to a treatment plan. However, if we notice it's going to fail from the beginning, by using the InnoBite, it will rectify all these scenarios. So some of the reasons to opt for dental implants in the normal bite force range are to prevent bone resorption, which is obviously most important, increase comfort, again aesthetics, improve quality of life, and self-esteem. That being said, we can also limit the amount of material for when we opt for an implant denture, so it's not as invasive for a patient. The less invasive a prosthesis is for patients, the more comfortable they will be. So there's always a reason to opt for dental implants, in my opinion. And by doing so, you're never going to have a patient, or I've never experienced a patient come into my office and tell me they wish they never went with an implant treatment. So implant treatments are definitely for a low value bite force, a light deficit, and normal bite force measurement. So a high bite force measurement with patients is seldom in the cases I've so far analyzed. However, they do exist. When they do exist, there are many things we need to consider. Strength of the prosthetic is most important. A patient that presents with over 1,000 newton centimeters will be basically breaking everything we do if it's conventional materials. So a lot of thought has to take place when dealing with a patient with such a high bite force value. Do we consider a fixed or removable option when determining which treatment plan is best available to the patient? In my opinion, a fixed restoration is much better. There's a lot more support we can use with dental materials that will help prevent further cracks, fractures, breaks, or failures of implant cases. And most importantly, a night guard is necessary. So, I know as denturists, the fabrication of night guards is not available to us, but it's a great tool for us to refer out to a dentist and tell the dentist, listen, hey, we have a patient here with over 1,000 newton centimeters bite force. This person needs a night guard. So again, the InnoBite provides us with many aspects of our daily encounters with patients, such as design, modified designs and future or referrals to our colleagues or our dentists that we work with, which help us in the end on a return on investment. So a reason to opt for dental implants with a high bite force value is obvious. For one reason is future bone loss, future resorption. We know that if bone resorbs and shrinks, the stability of their conventional dentures will also decrease. Therefore, their bite force will follow. I always opt for dental implants because we can maintain the value of their bite force, also allowing a patient to enjoy their quality of life throughout with a less invasive prosthetic. So we're going to go over some clinical cases and see how patients have improved using the InnoBite device. This patient here has presented with a severely overclosed jaw. Her dentures are approximately 12 years old. You can see from the pictures that she has a lot of wear on her teeth. Her bite is not in proper occlusion. So when we tested her, her initial measurement was 122 Newton centimeters. This was done at the insertion appointment of her new dentures. So we swapped out her existing denture, put in her new dentures, and she immediately went to 332 Newton centimeters, which is a great improvement. That being said, she's still under 400 Newton centimeters of bite force. So she is limited. Yes, we have an improvement. She is limited to what food she can eat. We also know as the muscles strengthen, I like to test patients, every 6 weeks, well, for now, to see how far we can get them on the bite force. In recent cases, I've noticed they do increase as their muscles strengthen, but not to the extent of getting to a normal bite force measurement. At the end of this consultation, by the patient seeing her maximum bite force is still under the 400 Newton centimeters and in low deficit or a low bite force, she decided to go with dental implants. In this clinical case here, the patient presented with some worn out conventional dentures. You can see in the picture above, the bite has wore down and he's almost in a prognathic bite or end-to-end bite. We converted him to 4 implants on a bar, and his bite force increased immediately again, as you can see, to 531 Newton centimeters. The stability of the lower alone helped us increase that value. This case is actually quite interesting. This is a 65-year-old woman with an 8-year-old prosthetic. During our initial consultation, she came in at a value of 223 Newton centimeters of bite force. She decided to go with dental implants. Now, the neat thing about this is we tested her when the healing abutments were placed and her stage 2 was completed by her surgeon. So we have a lower denture with 4 healing abutments only, and we tested the bite force again. At this point, we hit a value of 506 Newton centimeters. What's so interesting about this is the stability of the lower denture by just having tiny little healing abutments increased her bite force, almost by double. That's quite an interesting value to assess. Now, when the final prosthetic was completed, this is day of insertion too, so we have to remember the masseter will increase in strength, and I like to test all patients, especially at my recalls or any follow-up visits. I continually test my patients using the InnoBite device. She was able to achieve a 785 Newton centimeter value of bite force. So now she's in a great range to chew foods that she wants to eat, and her quality of life has increased substantially in moments. This 52-year-old woman presented with another interesting case, in my opinion. As you can see in the pictures above, she has severe periodontal disease and she's missing her posterior teeth. And as I mentioned earlier, the bite force is much higher in the molar region and premolar region than it is in the anterior. So essentially, when we tested her bite force, she had a value of 74 Newton centimeters. As we know from our chart provided by Cube Innovation, she's essentially eating a liquid diet or swallowing food whole, which we all know is not healthy for our digestive system and our bodies. She had her teeth extracted initially and went with conventional dentures. At this point, she was able to achieve 179 Newton centimeters of bite force, which is an improvement, but still very, very low on our scale of bite force measurements. After many discussions with the patient, she wanted to achieve a much higher bite force value, knowing that with a higher bite force value, she can then begin to eat the foods that she wants to eat and enjoy her quality of life. So she decided to go with a fixed restoration. With this case, we weren't able to test on the temporary provisional fixed case due to possible cracks and fractures at that point. So we tested her with her final prosthetic at the day of insertion. As you can see, this is immediately after inserting the final upper pros. She had a value of 628 Newton centimeters. Now, I know for a fact that 6 weeks in her post-op appointment, her value will be much higher. And as her muscles begin to strengthen, again, this value will increase. So I'm quite curious to see what will happen to this patient at our yearly recall appointment. These are a couple cases that were shown to me by colleagues of mine, which I also found interesting and thought it'd be great to add into this presentation. The first case is a 62-year-old man. His old dentures, he posted a 307 Newton centimeter bite with his existing dentures. On his new denture with a bar, he posted a 1,050 Newton centimeters. Now, the reason I think this case is so interesting is it's even using the Inabite. If we had a 307 Newton centimeter bite initially, it's kind of hard to predict that 1,050 Newton centimeter with the end result. Therefore, the structures and reinforcements needed in the case are detrimental to a successful case. Sometimes, using materials are, if you can imagine a case increasing their bite force as the patient progresses, it's in our best interest to almost over-engineer a case or over-design a case with structural supports to prevent breakages or fractures in the future. So some of the reasons we can use to measure our patients for the patient is education, most importantly. When we educate a patient and quantify a number, so they have a value they can attach themselves to see where they are on the scale of bite force, really helps. Also, it's expectations. If a patient presents and wants to chew all the foods, the first thing we always hear are steak, apples, all the hard foods a patient would like to eat. If they're presenting with a very low bite force, we know that this is not possible. So to be able to quantify for a patient and give them a number, the same number they would receive at any other test they would go to, such as hearing, eyes, any of those, they're all provided with a score or a test. Up until now, we haven't been able to do so. So it's quite exciting that we can help patients move forward with their choice of treatment option by quantifying their bite force. So what are some of the reasons for clinicians to use the Inabite device? Well, I think there's many. One being design and modify a case. So our goal when we meet a patient is to customize a denture. I mean, any one of us can fabricate a denture and insert it in a patient's mouth and tell them to have a great day. That being said, are we optimizing the case? By having a proper bite force, this allows us to, like as I mentioned earlier, give the patient expectations, but also allow us to provide a better treatment option in a much less time. So if I sat in front of a patient and told her or them how wore down their teeth are and they need dental implants, so on and so forth, they're basically just listening to what I'm saying. By providing them with an actual bite force measurement, they can visually see exactly where they are, and again, their treatment option will be a lot less chair time for us as clinicians to decide which route they want to choose. Also, again, design and modify. So no one wants to see a patient and fabricate a new denture. It could be conventional, could be an implant, could be whatever it is you're making, and 3 weeks later they come in with a cracked complete upper denture. We have no value up until now to be able to determine how the bite force will affect a treatment option. So if we can measure this out and determine exactly which route we want to choose, over design the case or design it accordingly, we're much further ahead. So chair time, what I've noticed so far, is decreased by just providing a value for patients. So I know I've talked quite highly of the InnoBite device throughout this presentation. However, I do want to note that I have not been compensated for this webinar, or am I affiliated with the company in any way. I'm just really excited to finally have a product or a device that I can use on a day-to-day basis that will help my treatment plans. So thank everyone. I'd like to thank everyone for joining us in this presentation. I'd like to let you guys know that I'm around for about 30 minutes for any questions you may have, and I will do my best to answer them for you. Once again, I'm truly ecstatic that the InnoBite device is around for us to use, because I think as denturists, we're looking to improve where we want to move to in the dental profession, and it's a great way to become accustomed to digitized dentistry, and it's so easy to use and provides great quality to our patients.